Okay, so today we will be talking about intrertrochanteric fractures, and we are going to try to analyze the most commonly seen physician failure associated with these fractures. So we all know intrertrochanteric fracture are a large part of orthopedic workload. We know that these fractures are commonly seen in mainly geriatric population, and these fractures are usually associated with high morbidity and mortality, but the mortality and mortality is exponentially increased by the implant failure. So the incidence of implant failure in these kinds of fracture is overall 2.5 to 7.3%, 2 to 7%. But in case of stable fracture, it is 0.5 to 3%, whereas in case of unstable fracture, it is 5 to 3%, 13%. So we can clearly see that the unstable fractures require special attention to prevent implant failure. Now, which are the fractures that are unstable? Kyle tried to classify fracture based on their morphology, and he defined type 1 and type 2 as stable fractures, and type 3 and type 4 as unstable fractures. But there are some inter-observer variability between, especially between type 2 and type 3, and there are some important components which were not addressed by the Kyle type, which needs special attention. AO has classified type A21 as stable, up to A21 as stable, and from A22, A2.2 to A3.3 as unstable. But then again, this has again inter-observer variability, and this does not often coincide with specific implant choice. So in case of, when dealing with intertrochanteric fracture, rather than going to a classification system, we have to rely on specific morphology that are considered, that will render the fracture to be considered as unstable. We know if a fracture has posterior medial comminution, it should be considered unstable. If a fracture is of reverse oblique type, it should be considered unstable. If a fracture has significant subtrochanteric extension, it should be considered unstable. And this is of recent interest. We will be discussing later on in details about this, that the lateral wall, if it is seen to be significantly comminuted, the fracture should also be considered as unstable. Now, regarding fixation and stability of this fracture, a number of implants have been used over the years, ranging from duet needle to 95-degree angle plate to proximal femoral locking plate or BCS even. But the time-tested implant for management of proximal femoral fracture, especially intertrochanteric fracture, has always been the dynamic hip screw, especially for the stable fractures, and the proximal femoral nail, especially applied for the unstable groups. So today we are going to focus the implant failures commonly seen in these two fracture patterns, and try to understand what problems could happen in other implants also from the failures of these two main implants. So dynamic hip screw has always been a good, reliable implant for orthopedic surgeon. This is an implant that is gives very good outcomes, especially in case of stable fractures. And inherent to this implant is the sliding compression mechanism that whereby the proximal and distal fragment impacts over one another and gives a good radiological bone union. Complications commonly seen in dynamic hip screw system are, we have seen some screw to cut out of the head. We have seen sometimes that the plate has separated from the bones. And this is another complication that is very grave aftermath. That is, sometimes we can see that even after good fracture fixation, there is some varus collapse, medialization of the distal fragment, significant limb shortening, which eventually leads to increased effort of walking, and eventually may lead to attendable gait of the patient. So how do we prevent screw cutout? It is a well-established fact that to prevent screw cutout, we have to maintain the TAD. And of note, during measurement of the TAD in both, which is a measurement of tip to apex distance in both AP and lateral plane, we must take into consideration the amount of magnification seen by our fluoroscopic uh, devices. And for placement of the screw, initially there were some controversies, but it is now again well established that a center screw, that is center in both anterior posterior and in lateral view, a center screw gives the best outcome in regards to prevention of screw cutout. Now, this is another complication that is that we see not many often, but we have seen that separation of the plate from the bone itself, a cortical shaft bone, and commonly this occurs when there is excessive varus stress. Now, this is of two importance. First of all, in this picture, this occurred due to the implant was given in a especially subcontract fracture pattern. But another thing to consider here is especially the patients in our especially the patient in our subcontinent, many of them have a neck shaft angle of less than 135 degree. Some have even a neck shaft angle of 125 degree. Now, a 135-degree implant is placed in a neck shaft angle of 125 degree. That will increase the varus stress over the plate, and that may eventually lead to cutout of the separation of the plate from the bone itself. So it is very important to have a pre-operative X-ray of the normal hip prior to the selection of implant, and give appropriate angle implant according to the patient. Now, let's analyze this fracture. This is a intrertrochanteric fracture. One would argue that this is a stable one. This is a lesser trochanteric fracture, no significant comminution. And initially, the treating surgeon treated it with a dynamic hip screw. And we can see the reduction is acceptable. The placement of the anterorotation screw is parallel. So overall, this should be considered as a good operation. But as we all know, enemy of any orthopedic surgeon is the late postoperative X-ray. And from the postoperative X-ray, we can see that there is varus collapse. Distal fragment has migrated proximally, and overall, this is not a very good outcome. This is not something we want. So, what would be the cause of this fracture converting into this? Now, if we focus here, we can see that while insertion of the screw, there was fracture of the lateral condyle. And what this did was, first of all, by fracturing this lateral thin plate of bone, which is the most important part, when the treating surgeon fractured this lateral piece of bone, he converted a stable fracture into a reverse oblique fracture. And obviously, we know we cannot use DHS in a reverse oblique pattern. But of note, which is of recent interest, they are saying that this lateral wall is very important, because this lateral wall actually is provides the main buttress against which the proximal fragment has to buttress upon. And injury to this lateral wall, injury to this lateral wall preoperatively or paraoperatively actually leads to this varus collapse of the bone. This theory was actually first introduced by Gottfried on 2004, who first theorized that the lateral wall is a major factor in determining internal fixation devices, which was later on addressed by Palm and colleagues, who showed in their journal that lateral wall was the main predictor for reoperation after intrertrochanteric fracture. And they recommended that if a patient has preoperative or intraoperative fracture of lateral femoral wall, it should not be treated by a sliding hip screw. Now, this was a journal published on 2015 by Shu and colleagues, and this was a very good journal. In fact, they quantitatively measured the amount of the lateral wall needed for securing a stable DHS, and from their study, they found this number, that 20.5 millimeter, and they suggest that this is the minimum amount of thickness of the lateral wall that should be there, so that a DHS mechanism is sufficient enough, and the lateral sufficient enough, and the lateral wall is thickness is sufficient enough to buttress the proximal fragment. If we put a DHS in a thinner lateral wall, the proximal fragment would collapse and fracture the lateral wall and eventually lead to a varus outcome. This theory actually was adopted by AO Foundation in their 2018 fracture reclassification compendium, and they based on their proximal femoral intrertrochanteric fracture based on this lateral wall, and they have adopted this lateral wall thickness into their classification system. They are saying now that if our lateral wall thickness is more than 20.5 millimeter, it should be classified as stable. And if a fracture pattern is lateral wall has less than 24.5 millimeter, the fracture should be considered as unstable. Now, this is a place where proximal femoral nail actually clearly stands out in regards to DHS. The proximal femoral nailing system itself provides some sort of buttress against which the proximal fragment or neck head fragment can give pressure. And we also know that any intramedullary device is far better compared to an extramedullary device. So initially, when we started doing proximal femoral nail, some good results were there, and we thought our problems were finally over. Initial results showed that proximal femoral nail gives superior outcome and functional recovery compared to dynamic hip screw. So we were happy, but this was far from the truth. Eventually, once we started doing more and more PFN, number of new complications unique to proximal femoral nail system have emerged. We have seen proximal femoral nail to break. We have seen Z effect, especially in two screw system. We have seen shaft fractures, and the wedge effect is commonly seen during introduction of proximal femoral nailing. And we have seen lateral wall fractures due to placement of the proximal femoral nail. Now, breakage is something that is infrequently related to the length of the nail used. And there are controversies in regards to what is the optimal length of the nail. Some say at least 4 centimeter of subcontinental region is required. Some say about 2 centimeters is required. But in general, the message is whenever a surgeon is in doubt, a relatively longer proximal femoral nail should be used rather than going for the shorter one. Now, static locking, this is another controversial topic, whether or not to statically lock a PFN has been of some concern. And to some extent, especially in case of osteoporotic bone, it is advised not to statically lock the bone. As we know, the compression mechanism in between the fracture fragments are very important for bone union. And if we statically lock the bone, we are only relying on the bone to compress over this segment, whereas if we do not use the static locking, we can have two places of compression of the fracture fragment, both the distal and the proximal one. Now, bow mismatch is something that is that should be carefully looked for, especially if we can see in this X-ray, the AP X-ray was relatively good, but on lateral X-ray, we can see that there was anterior cortical contact of the nail with the bone. But the surgeon was satisfied. But later on, as we know, the postoperative X-ray are not always what we think of, and there was cortical shaft fracture. So we have to be very careful during bow mismatch, and especially what we must remember that when inserting the nail, the nail should not have to be hammered. If we have to hammer the nail, then there is something wrong in regards to the bone. The nail should easily glide to a central position of the canal. This is something that is also infrequently seen, that using a thinner nail to reduce the operative time. Now, what a thin nail does is when we use a thin nail and a relatively large diameter osteoporotic bone, nail starts to toggle, and this toggling effect increases the cyclical loading over the screw system, which may lead to the Z effect, and also may lead to varus collapse and delayed union of the bone. So appropriate diameter of the nail should be chosen according to shaft dia. Now, this Z effect, there have been published system. This is a complication that is commonly seen in, that is infrequently seen about 4% of two screw system of proximal femoral nail, and they have addressed the reason. This journal have addressed the reason behind the Z effect, but we want to focus on two things in regards to the migration of the screw. Now, the lateral migration of screw, like a medial cortical communication, is not something that we can control, but the lack of the bony purchase of, to prevent the lack of the bony purchase of the neck, the screw given in this two screw system should always maintain that, first of all, and to prevent toggling we should maintain appropriate diameter of the nail, so to prevent the lateral migration of the inferior screw. And for medial migration of the superior screw, we should no, for prevention of medial migration of the superior screw, we should use appropriate angled device. So this is something that is again seen commonly, especially when we are using a rima, we are using a bone owl that is not too sharp. We have seen after initiation of the entry point to lateralization of the entry point. Now, if the entry point lateralizes from the tip of the trochanter to the fracture site, what that does, it gives a wedge effect, and that may lead to loss of our initial reduction achieved. And this loss of reduction not only delays the healing, because we have to remember that our bone cannot unite with implant, and this will overall give us a poor outcome. And regarding entry point trajectory, again, we must place our guide wire. This is a picture depicted from AO compendium, and they have showed that if we place our guide wire lateral to the tip of the trochanter, the trajectory would be towards the medial aspect of the bone. Now, if we can keep that entry point medial to the tip of the trochanter, the trajectory would be towards the shaft of the bone. Now, one would argue about the 5 to 6 degree mediolateral angulation at the proximal segment, but to be frank, this is 5 to 6 degrees, not something that is that is of great concern. And if we give the screw trajectory in the medial surface, it will lead to a nice center placement of the nail. Now, if we analyze this picture, we can see here that this was the fracture, and this was the proximal femoral nail was done. Medialization was centralization of the nail was not done due to faulty trajectory of the guide wire, and the TAD was not maintained. And this has overall, and the nail dia is also thinner compared to the shaft, and this has eventually led to Z effect and varus collapse of the bone. Now, regarding whether we choose dynamic hip screw or proximal femoral nailing system, the key outcome measure in proximal femoral fracture is actually the fracture reduction. And this is a study initially done by Cheng and colleagues, which was based on their prior study on 2009, most probably, who analyzed about 39 intertrochanteric fracture. CT scan analyzed with 39 intertrochanteric fracture, and from that they found that most of the fracture have posteromedial continuation. That the first information. And secondly, they found that in most cases, the anterior medial cortex is actually intact, and they wanted to leverage from this information. And they so according to type of reduction, they classified the fractures into three subgroups. It could be a positive reduction where the proximal fragment has overlapped into over the distal fragment. It could be a neutral reduction or anatomical reduction, and it could be negative reduction where there is varus angulation between the proximal and distal fragment. And which one do we want? Now, one would argue that we want an anatomical reduction, but interestingly, what they found that if we achieve a positive reduction, this will actually give a better outcome in regards to the fracture stability and maintenance of the angulation. And this positive reduction not only should be achieved not only in anteroposterior diameter but also in lateral diameter, which was confirmed by Shang and colleagues in their 2019 study. Now, in the study, they showed that the neck shaft angle achieved by positive reduction is good. There is a decreased LLD following the reduction. Time of full weight bearing is less, and overall hip pain is significantly less compared to the negative, and in compared to the neutral reduction. Now, I know this is something that is contrary to our knowledge. Now, we always have known that anatomical reduction is the best choice, but more or less the data is still overwhelming that achieving a positive reduction actually is better. Now, why is that? Now, if we carefully look at this fracture site, now when we are doing an anatomical reduction, we are relying on this anteromedial cortex, which is actually relatively much thinner in osteoporotic bones. Now, this thin cortex is actually often not sufficient enough to prevention of the varus collapse. Now, if we give a valgus or positive reduction, there is decreased chance of varus collapse. So this study outcomes seen in these studies is justifiable actually. So to achieve this positive medial and anterior contact, number of ways have been described. Some has used Steinman pin over the head. Some has used bone levers, or in our perspective, we can use a periosteal elevator. Some has used bone pusher. Some has used K-wire. So number of techniques, but whatever the technique applied, a surgeon should go for a positive reduction to have a better outcome. Now, what to do after we have reduced the fracture? We should provisionally fix the reduction with a K-wire. Especially in case of fixation of the K-wire, we should keep in mind that the K-wire should not pass in line, go in line with our implant. Otherwise, we have to remove the K-wire during introduction of the implant, and that may cause failure of reduction. Now, what about the lateral wall, especially in case of PFN? Now, this is another thing that is of some debate till now, and they have shown that if we fix the lateral wall, even in case of proximal femoral nailing system, this gives a better outcome. But this gives a better outcome, and a number of devices have been used for fixation of lateral wall, like K-wires or specially made plates, and they have showed that when the lateral wall is reconstructed, this gives overall a better bony union and overall better functional outcomes in regards to intrertrochanteric fracture. Some other implants have been used over the years. Implants like proximal femoral locking plate, dynamic condylar screw, proximal femoral trochanteric stabilization plates, etc. And which implant is best for intrertrochanteric fracture? That is still again a big topics. We have to consider a number of factors like metaphyseal morphology, factors like fracture reduction, factors like shaft morphology. That is another concern. So we are not gonna go to that details, but we should go to American Association of Orthopedic Society tips to have a better outcome in orthopedic intertrochanteric fracture management. They have summarized the information as: if there is no lateral wall, we should not go for a hip screw, and reduction is the key, as we have seen, and a surgeon should not hesitate to go for an open fracture, should not hesitate to go for an open reduction. We have to know the unstable fractures and we have to nail those fractures. We should be aware of the anterior bow of the femur and shaft to prevent shaft fracture. Now, when we are using a trochanteric entry nail, it should be medial to the tip of the trochanter to have a good nail trajectory. We should always keep a dynamic hip screw standby. We should be cautious with our nail trajectory, and we should never have to use hammer. If we are using hammer, we are doing something wrong. Um, uh, we should avoid varus proximal fragment fixation, and we should use the relationship between tip of the trochanter and the femoral head to know the fixation angle, neck shaft angle. Lateral wall should be stabilized even in case of nail, and we should have a good anterior and medial contact, and we know we should go for positive contacts in case of anteromedial cortex. So overall, I know evidence are new and intriguing, but evidence is something that is ever changing, and evidence are actually conflicting. So for these conflicting evidence, we need the opinion of our panel of experts. So in this regards, I refer to our panel of experts for further opinion regarding this presentation. Thank you.